Today we welcome Michel Labrecque. Michel is a full professor, recently retired, from the Department of Family and Emergency Medicine at Laval University here in Quebec. Researcher at the CHU de Quebec Research Center and also a member of KC Canada. His activities have been marked by constant concern to evaluate promising clinical approaches and integrate them in practice. In recent years, his research activities focused on knowledge translation strategies to improve medical practice through shared decision-making and information technology. He received the Family Medicine Researcher of the Year National Award in 2014 and was recognized this year as one of the top 20 pioneers of family medicine research by the College of Family Physicians of Canada. For his research in men's health, specifically his research on vasectomies and their procedures. Today we'll talk about under the belt, but rather over the shoulder. The title of his talk is Evaluation of Behavior Change Interventions to Increase the Use of Pneumatic Otoscopy in Family Medicine, a pilot randomized controlled trial.
So it's Sophie. So we'll jump to the objectives of the session today. So they are to understand the importance of conducting pilot study of complex behavior change intervention trials, highlight the importance of long-term follow-up in behavior change intervention, and discuss the lesson learned and the methodological challenges related to a larger trial. So first I want to acknowledge my co-investigator, Eva Ouedaogo, who she's in Gaspé. Actually, she's attending the meeting. Bonjour, Eva. Also France Légaré, Michel Cochon, and Émilie Tardieu. And also our sponsors, actually, KC Canada provided funds for seeding fund for this study, and also Canada's Health Research Foundation for helping Eva starting her research career. So today we'll first look at the background, preliminary studies, development of the intervention, pilot study, the methodology of the pilot study, results, lessons learned, and something about the next trial. So the background. What is pneumatic otoscopy? Actually, it's a diagnostic procedure that is used by clinicians, and it's needing only a little bulb that you can see in a special speculum that you put on an otoscope to assess the mobility of the tympanic membrane. So I'll just show you a short video on what it looks like when you're using this tool. Here we go.
Pneumatic is performed with a structure that's larger than the size of the ear canal. Only a structure is required to achieve movement of the brain. Like the best point can be seen on isotopsy, the middle ear. If no field present, examination will be inaccurate because field is required.
So, and it's required also to, and the mobility of the tympanic membrane will be absent if there's an otitis media. So we'll go back to the presentation. Actually, this tool is recommended in all North American guidelines for the diagnosis of otitis media. Actually, has been there for the last 10 years, and just to show you the recommendation, in 2004, clinicians should use pneumatic otoscopy as the primary diagnostic method for otitis media with effusion, a strong recommendation. And more recently, in 2013, clinicians should not diagnose acute otitis media in children who do not have middle ear effusion. Strong recommendation also, and the pneumatic otoscope is the standard tool used in diagnosing otitis media. So the recommendations are quite strong, but our family physician using pneumatic otoscopy, actually, as a clinician, we had the feeling that the answer was no. We didn't have any evidence, strong evidence about that. So we started a series of studies that in 2011 to assess the situation. So, as you know, the knowledge to action cycle suggests that the first thing we do is to identify the problem. And here we wanted to know if there was a gap between the use of the tool and what is recommended by the guidelines. But we also to know if there was a difference between what we know, what is recommended, and what we should be doing. If what were the barriers and the facilitator to that knowledge use, according to the cycle. So we studied and it was published in the Canadian Family Physician in 2013. And what we found is that our feelings were right. The regular use of pneumatic otoscopy was only in 4% of the physician from the 12 family unit in Quebec City. So that's very, very low. The equipment was fully available in only 4 of the 12 teaching units. The mean intention to use was low also, 2.4 on a scale of 5 is not very high. But 80% of the residents want to learn the technique, which is a nice finding. And the main barriers were the equipment. Of course, if you don't have the equipment, you cannot do the technique. There were some doubts and beliefs, disbeliefs about the clinical utility, although the evidence is pretty strong. The capacity to perform, as nobody's performing it, the capacity was not there. Of course, as were the norm and the role modeling, a lot of people didn't know about the guidelines recommendation. Step was to do a study to implement intervention or to implement the intention in practice according to the action cycle. To guide the development of intervention, we based our action on the guidance model from the MRC for complex intervention. As you can see, there are 4 elements: development, feasibility and piloting, evaluation, and implementation. And again, it's a sort of a cycle. We seem to like very much cycle in TD research. And our first step was the development of the intervention. We look at the theory behind the behavior change technique, and there was this nice article published by Michel in 2008, and they mapped the determinants of the behavior with the techniques that are most effective to change the behavior. And there's another page of that. We won't go through the details, but what we did, our first task was to map our determinants, the capacity to perform the technique, the clinical utility, the beliefs about that, the social professional norm, role model, environment, to the behavior change technique that were considered as most effective according to the literature review done by Michel. But that's a bit complicated, and there was a lot of behavior. So finally, we modified it and built our own framework based on that. And you can see that there are some interaction between the belief, the utility, the professional role, and also the techniques. At the center of the model, there's the equipment. As I said, no equipment, no technique. But we are looking at the different techniques, the persuasive communication and hands-on training and complementary intervention. Around those 2 main interventions were our model and the way we did the intervention. What we did, first of all, we did a first workshop. We developed a first workshop on persuasive communication. Actually, it was a 60-minute workshop, and the workshop was designed according to what is most feasible and most effective. And thanks to Jeremy Grimshaw for his nice literature review in 2004, we had the main ingredients. So it has to be short. 60 minutes, we thought it was quite short, small group, interactive, at lunchtime, and in work setting. Those were the most feasible for the clinician. And it was based on the elaboration likelihood model, the ELM, and this model that there are two ways that people can be persuaded to change their behavior. There is first the central route. The central route is based on cognitive. You give people the evidence, they read the evidence, and they make the change. But there are some people that are not that convinced by that, and they are convinced by the peripheral route of persuasion. So how is it packaged? Is it nicely done? Who's the person who's presenting? So you have the content, and the container. So this is the how we manage. So we took our time to do an intervention that would be also nice but fully evident. So the messages were on clinical utility, role modeling, social professional norm, the practice guidelines, and also capacity. We wanted to persuade them to go online and do a course there's a course that exists to train on pneumatic otoscopy, and we trained them how to access the course. The messages were reviewed by an expert from the Montreal Behavioral Medicine Center. Really, we tried the intervention to be as as possible, reinforcement of positive attitude, but we also had counter-arguments to negative comments. For the workshop, there was a phase where we asked the participants to do action plan, their action plan to implementation of the technique in the family medicine unit, and we pre-tested the workshop in one center in 2012. So we also developed an hands-on training workshop. It was also 60 minutes. After a brief presentation on how to perform the technique, people were asked to go in stations, 3 stations, supervised by an expert peer. One was a practice between colleagues, and the other 2 with ear simulator. And in one station, the ear was with effusion, and the other one without effusion. And after the practice, people were coming back and doing their action plans for implementation in that workshop. So which one would be the best approach, the best workshop? So we decided to do a combination of both. Actually, it's not a real combination because it's not 2 hours like, we had 2 60-minute workshops. It was a 90-minute workshop. We can cut at the beginning with the introduction, and the action plan was the same in both. But we had to condense the activities to put it in 90 minutes. 2 hours was considered to be a lot too much. So first step, according to the MRC guidance, was to test the feasibility and piloting the procedure, but at the same time, we wanted to explore the effectiveness of our intervention. So we did this pilot study over the last 2 years, and this is the phase according to the knowledge to action plan, the selection and implementation of the intervention. And according to the action plan, again, we wanted to monitor the knowledge use. We took the opportunity of, when we went back to the units a year after, to present the result of the first step of the studies, we asked about, we evaluate the sustainability of the knowledge used according to the model. We didn't evaluate outcomes because the outcomes, we know that if you use pneumatic otoscopy, you will decrease the use of antibiotics and you will be more precise in your diagnosis. This is already known. So the objective, I won't go through all the specific objectives, but there was some objective of feasibility and acceptability of the intervention. So recruitment, reliability of the method, the most appropriate method. And we want also to explore the effect of the intervention on actual use on short term. So so the use in practice, but also on the intention and self-reported use, short-term and long-term. So the study was a cluster randomized trial in 4 family practice teaching units, and it was inspired by a 2x2 factorial design. And I say inspired because if you look at that slide here, this is exactly what you would be presenting for a 2x2 factorial design, where then at the same time evaluate 2 interventions, intervention A and B, independently from each other. But our combined workshop was not exactly the addition of the two other workshops, and we thought that there would be a lot of interaction between putting together those 2 workshops. So in this pilot, we considered them as 3 different interventions, and our analysis was done with 3 different workshops, like 3 different workshops. We'll go through that step by step. I'll show you. This is exactly what we did, and I'll give you the result on feasibility. Then we're going through the steps. So the first thing was to assess the eligibility of the family medicine unit. We assessed it in 9 units, and we started with the urban area, the Quebec City area, because our money was we just seeding money, so we couldn't go all across the province. So we started with the unit in Quebec City, and we went to more peripheral units. But still, it was pretty good. On 7 eligible units, 6 accepted to participate. So it was 86%. So we were pretty happy with our recruitment. And the 4 units were randomized to the persuasive communication group, hands-on training, combined group, or control group. You can see here that the physician here, the eligible health professional, who were they? They were physicians or nurse practitioners. We had just a few. I think we had 6 all over the units, but they were participating also. And they had to intend to practice in the unit for the next 12 weeks, at least for the first part to be practicing. So we excluded some people who were, for example, on maternity leave, or were going abroad, so or in sabbatical, they were excluded. You hear that the number is not the same. So we had a smaller unit here with 13 participants, but we had bigger urban units here. So the step was to conduct a survey, a baseline with baseline measure, including intention to use and reported use of the technique. Our completion rate was pretty good, from 67 to 93%. And then the units in the experimental groups were invited to attend a workshop. So you can see here that 70%, 56%, and 85% of the eligible physicians, not only those who completed the survey, accepted to participate in the workshop, but they were all the same here. The satisfaction of the workshop was very high. I don't have the result here, but everybody completed the satisfaction measure after the workshop, and that was pretty good. Then we had to measure the actual use in practice 6 to 8 weeks after the workshop. And then to do that, we had to recruit patients. So who were those patients? They were adult or children, and in 2 phases. Their eligibility was assessed in 2 phases. First, they had to consult for symptoms compatible with otitis media. We had a research assistant in the walk-in clinic who was assessing this first criteria. And then, after coming out of the consultation, the attending health practitioner had to judge it necessary to diagnose or rule out otitis media. So they had a ear problem, and it was obvious that it was coming from toothache. They were not included because they didn't need a pneumatic otoscopy. But it was depending on the practitioner judgment for that. So you see that we had all our patients. They were recruited over 2 or 3 weeks. And it's not all the eligible physician or who recruited the patient. Of course, it was only on 2 or 3 weeks, and they don't do the walk-in clinic, all of them. So we were quite satisfied with those numbers there, and they're quite normal. Then we had to measure the actual practice. So we envisioned different techniques to do that, to be as objective as possible. And those techniques were thought about, but they were not used. The first one was to put an electronic chip in the otoscope, but actually it proved to be much more difficult than we thought, a lot more expensive, so we discarded this approach. The other technique we thought was a video of all half-day session of consultation, like surveillance camera in the room that would register the consultation. The other was picture of the pneumatic otoscope and the count of speculum before and after each encounter. But we validate those 2 approaches with a family medicine unit that is not participating. And actually, it was clear that if we were doing that, we wouldn't have anybody participating. It was like too much of a spying them during their consultation. So finally, what we did, we relied on questionnaires, practitioner questionnaires, and patient questionnaires. Patients actually were primed before the consultation to recognize the tool. So they knew when, after coming out, they knew what we were talking about when we're talking about pneumatic otoscopy. And also we asked the research assistant to take pictures of the otoscope and speculum tips before and after the beginning of the clinical session. So the half-day session, in the morning, on the afternoon. Those were the technique we did. So after this 2-3 weeks period, we also asked the eligible physician and practitioners to complete another survey. So that's 8-11 weeks post-workshop. And again, the completion rate was quite good, from 53 to 79%. And then a year after, when we returned in the units to present the result, we asked the people to also complete a 4th survey. And about between 60 and 70% of the participants to that 14-15 months survey that were eligible at the time we did the first phase of the study. So that was maybe half and half, or 60-70%. So results on impact. So what about the actual use of pneumatic otoscopy? So the questionnaire you see here, when we were asking the practitioners if they used the tool, it was used in 43% of the cases. Patients said 41%, and the picture count 66. And actually, that's probably because some practitioners saw more than one patient during a half day, maybe 2 or 3. So as we couldn't know if they used it on the patient, it was probably an overestimation of the practice. And when we looked at the agreement between practitioner and patient, you can see that it was pretty high. 90% of the time, the patient and the practitioner were agreeing that the tool was used. The kappa was 0.8, so we thought that would be the best outcome measure we could use to be as objective as possible. The one you see, the kappa was 0.5, 0.4. So the result I'm going to present to you is based on those cases where both practitioner and the patient said that the tool was used. So what are the results, the actual use? In the control group, 21% of the time the pneumatic otoscopy was done when it was supposed to be done. In the intervention group, it was much higher. You can see it was 52%, 56%, 62% according. So it's quite large. And if you do a chi-square on that distribution, the p-value is significant, and it's all the significance come from the 21% versus the rest of the group, because there was probably no difference when you partition the chi-square within the other group. Now, what's the intention? I could present you all the figures like that, but it's much easier like with a graph. You can see that the intention of the practitioner before the workshop was 3 and 4, 5. So it was more than the pre-study. It was 2.5. You remember that? So probably there was an effect that they knew that we were going to do a study on them. So attention was probably higher than if just the real life situation. But after the workshop, the increase was quite significant. You can see it gone like 2 points, almost 1.5, 2 points on a 7-point Likert scale. After 11 weeks, it was down a little bit, but still high. 14, 15 months, it was back to the control. Completely back to the control, even less than before the study. And we also asked, well, this is the proportion of practitioners who intend to use the tool in the next month of their practice. And you can, before the workshop, it was very high. Even 80% said, yes, I will be using it before the workshop. And the workshop was very effective. In all the units, it's almost 100%, 90, 95, 100% of the doctors who attended the workshop intend to use the tools. So we were quite persuasive in the sense that the workshop did its job. Even 11 weeks after 8 to 11 weeks, it was quite high, 70% to 90%. But a year after, you can see it was down the drain. It was back to the control. Still, it was 30%, but it was back to the control. How we asked the patient, not the patient, but the practitioner, if they had participated or not in the workshop. Those who participated said yes, it was 37%. And those who said, no, I didn't participate, it was 28%. The difference was not statistically significant, but there was a little trend. The sample was not very, very large at that point. So it was an outcome. And the other outcome was the reported use in the last month before the questionnaire. And you can see that it was never used in the month before by 80% or more of the physicians. That's before the workshop in pale blue. And this is the total group, including the control group, just to show you the difference. And you see that after the workshop, there was a tendency to use it at least sometimes in dark blue. If you look at 14, 15 months, in the before, it was back to 80% didn't use it in the month before the last survey. And if the distribution according to the study group, you can see that the shift was larger. Here you see the shift here. I'll just draw. Here the shift is there, and there. In the experimental group, there was a little shift also in the control group from 80% to 60%. But when we asked them 14, 15 months after, you see 95% the control group didn't use the tool, but it was about to 80%, 67, 85% in the experimental group, but it was still high. A lot of people were not using it on long journey. Why is that? We don't know exactly, but I can tell you that they didn't comply with their action plan. The experimental family medicine unit had said, we will complete the online course on otitis media. Only 5% of the participants did, and partially. We will get for training. Nobody did. We will practice on normal adults. 14%. We will ask residents to do it. 22%. So they didn't apply to their action plan. And we also, for the barriers, why, if you didn't use it or you don't intend to use it, why is that so? So the barrier were the same, exactly. The belief about clinical utility, the capacity to perform, a little less equipment and a little less the role modeling and the norm. But what is funny is that when we were asking the people who were using the tool, what are the reasons why you're using the tool? They said exactly the same. They said, oh, it's very useful clinically. I'm going to be more precise in my diagnosis. I can give less antibiotics. And very easy to perform. I don't know what to think about that. We also asked, if you were to perform another RCT, what would you prefer as a workshop? And actually, it's overwhelming. Everybody wanted the combined workshop. And those who didn't said, I would like the hands-on training. With the hands-on training, it's a lot more work for us to do. We have to prepare the station. We need to be more than 2 or 3 or 4 person experts doing the station. So, but the is there. Everybody wants the hands-on work, the hands-on training, and plus the combined workshop. So the lesson learned, the main lesson is first, the RCT is feasible. We demonstrated that it was feasible, at least in family medicine units. I don't know if it would be in groupe de médecine familiale, family medicine group, in the community, but at least in teaching setting, it was feasible. The intervention, all the interventions we did were effective on short term, but none interventions were effective on the long run. But maybe enough to get the early adopters on board. You have to remember that it's an intervention, that it's a tool, that it's not almost used at all. So maybe we need to pass by the innovation adaptation life cycle. And you have early adopters and innovators, they constitute about 16% of the people who are starting a new innovation. And we're at that stage, more or less. About 20%, 15% of the people still using the tool, the diagnostic tool, even on the long run. We were expecting a lot more. We were expecting to stay stable at 50% of use, but maybe we were too greedy in our expectation. So maybe that's normal to have those results. So what are the next trials? We'll base our next trial on our conceptual frameworks, on our theory-based models, and to design our PICO questions, like population, intervention, control, and outcome. And I have some question about that. So for the population, should we do further intervention in the same cohort? Maybe early adapters, and they could move to the early majority and then to the late majority. That's a question. Or maybe we can use different cohorts, teaching versus non-teaching units. Should we go in the community and try it? Family medicine versus and pediatrics. If the pediatrician as specialists were using it, maybe they could teach the family doctors also. Should we do another pilot, or we go on and go in a larger trial with all the information we have now? It's quite obvious that the combined workshop is the desired, and we would go that route with both persuasive communication and hands-on training. But we really need to add other intervention to sustain use if we want to have this effect. And I just put some IVs there: contracts, audits and feedback, reminders, rehearsal of workshop or rehearsal of practice over the year, using opinion leaders, and maybe the early adapters in each unit could channel the technique in other units. Maybe others. I'm looking for your suggestions. In we need to confirm the short-term use. We did that in only family medicine unit, and we need more power to really confirm the short-term use. We need to measure the long-term use, but then how will we do it? Should we look at the actual use and look at the patient and questionnaire? Actual use, actually, I think there was some Athorn effect when we got the actual use. They knew that we were aiding them, and probably that's why we had such a good result. And it's very intensive, very labor-intensive doing this sort of evaluation, but it's, let's say, objective. So probably in a larger trial, we would keep them on long term also. But we would also have the self-reported and the intention, because we can see the differences, and it should be moving all in the same direction to confirm that's working or not. And also read some qualitative data, as we did in our previous studies, to better understand the result, either negative or positive. And it would help because we have a lot of research on knowledge transfer of, I would say, when the guidelines are so strong about doing an intervention or doing using a medication or doing an intervention in clinical practice, and it's so I would say the implementation in practice is so low. So the information we get on the study on pneumatic otoscopy can serve for other situations in medicine where the guidelines are very strong and they have recommendations, and the doctors or the health practitioner are not applying the intervention that are suggested or the recommendation. So will practitioner use pneumatic otoscopy as a routine in practice? I don't know, but one thing for sure, we still have a lot of work to do before we know the answer. Thank you.
Okay, so thank you so much for that very interesting presentation. I will be asking each site if they have questions, and I'll be starting with Dalhousie, and I'll move west from there. And I just want to remind the rest of the audience who's listening with their own computers that if they have a question, they can send it to me via the chat box on the WebEx, or they can email it to me. So we'll start with Dalhousie. Does anyone have a question they'd like to ask there?
Any questions?
Okay. How about at Laval? Okay, make sure that we can hear them if they're in the room with you.
Okay, well, they will ask the question and I will repeat it.
Okay, sounds good.
Very.
The first one is there something particular about the early?
Pardon me?
Is there anything particular about the early adopters?
Okay. The question is there something special about the early adapters? This situation, actually, I don't know, because we didn't identify them truly. We couldn't know because we had the number of the doctors and the practitioners, so we couldn't know. But they seem to be distributed in all the units, and even the control unit, there were 2 or 3 people who seemed to be keen to use it, but I don't know more detail about that. So, but in general, early adapters are usually people that are innovative. They like kicks, and they like to try. They usually younger people, but that's I don't clear answer for that question. What is your second question?
What about the intervention itself? How is it possible to know if the dose is enough to bring about behavior change?
Okay. The question is about the intervention. How to know that the dose of the intervention is enough to make a change? What I would say is, in that study, we were able to make a dramatic change in the short use of the, and the dose was what I presented. It's a 60-minute workshop or a 90-minute workshop. So it's a workshop in setting at lunchtime in the family medicine unit. So that's the dose we did. Now, what we need to do is look at the theory base behind what type of dose we should look at to the sustained use. And this is a good question. So we might need some pilot study to do that. And that's what I was thinking of, going back to the cohort and see what sort of whip we can use to have them use the tool. And
Two questions also. One about the method. I know there is a method that we use in constraint-free principles, but those who like the intervention, do you see a difference in their retention or in their actual use?
We look at that, and there was not a big difference. There was a small difference, but the sample was not big enough, to make comparison. But there was, what I remember, I don't have that here, but there was a little difference, but not that much.
My second question is about, I'm surprised by your conclusion that you're saying that you want to use the combined intervention because the impacts are the same.
Yeah.
So why you say people prefer it, but it's so much more labor intensive, so why would you go for combined intervention?
Because of what people want. And I think that is important. When we asked the question, we said that this intervention is longer, okay? It's more intensive. We put all the factors, and people say we want to practice. And hands-on. If we were to give only the hands-on training, I would say I'll add the persuasive because it's sort of part of, so it would be only 30 minutes more, and you give all the bolts and nuts of what you should be using it.
But it didn't have more impact.
No, you're right. You're right. But this is a pilot. Actually, there was a small difference. The units were not the same, but it was 62% versus 56, 52%. So there's a small difference when they combine. Interesting. Thank you. Okay, more questions?
All done with your questions there?
Yeah.
Okay, I have quite a few. I'll go through the sites first, though. Any at McMaster?
No, but we want to thank you very much for the presentation.
Thank you.
Thank you. Anyone at University of Manitoba?
None from our site. Thank you very much for the presentation.
Thank you.
And lastly, do we have anyone from the University of Alberta with a question?
No questions. Thanks.
I have a few here from our listeners. Okay. So, first one, could you please remind us what the control group had in the CT, and would you also be willing to share your slides with the group of attendees? Well, we can take care of that. It
will be a pleasure to send you the slide. I will send that to send them to maybe after the session. That's no problem. The control group, what they did, they had only an information session of about 10 minutes. I just told them that you will be participating, and we will be measuring the use of pneumatic otoscopy, and we put the equipment in all the rooms. So we're not totally nice in that sense. But as I said, no equipment, no trial, because they didn't have the equipment. So I just presented this, and we gave them the URL address of the online course for if they wanted to go, and that was it. But no message, no persuasive communication message.
Thank you. And so a second part to that question asked, did you use a theoretical framework to identify the barriers and facilitators, and if so, which one?
It was a theory of the planned behavior, theory of planned behavior.
Okay. All right. So next question. Were any predictors of clinical behavior change measured, for example, self-efficacy, habit, etc.? And if so, did the intervention result in any change in these predictors?
No, we didn't have any of those. But that's a very good suggestion that we could add those questionnaires if we were be doing. And this would help, like Selma proposed, that we would know if the early adopter has a different mindset regarding the use of the tool. Very nice suggestion. Thank you.
Okay. Okay, and the next question. I would like to know the difference between an intention and a behavior, or what's the moment that an intention changes to become a behavior? Is there a intention at 14, 15 months is really an intention or a behavior?
It's an intention, because the intention, when we ask about it, it was about what would you be doing in next month. We were always putting a time frame. Would you what is the probability that you'll be using the tool over the next month, or and they were putting that on a Likert scale or a percentage, and like 3 questions looking at the same, to measure the same thing. So the behavior would be, did you use the tool last month? So we were retrospectively asking them if how many times in the last month for a kid or an adult with a suspicion of otitis media did you use the pneumatic otoscopy? And the result in that I presented you, like never, it was they never used it in the last month.
Okay, thank you. Okay, so another question from the crowd. She asked, are there other factors than those found in the qualitative data that you feel may help explain the dip in intention or use at 14 to 15 month follow-up from anecdotal evidence, for example?
That would be part of qualitative inquiry. I would say, you would collect all that, and even if it's anecdotal, I mean, it could help understanding the results. So I say it's just a matter of asking the right question and doing the inquiry with the data.
Okay.
Of any specific, even quantitative or qualitative, but qualitative will really help if you have, it could be a focus group after in the units, it could be a question done in the questionnaire, open question or discussion after the workshop. Those are some sort, like the last time we presented in a unit, I remember an older doctor told me, now I don't use it anymore because they changed the speculum, and you have the otoscope. It's like any cars, they change a model so you can buy more. So they changed the model, and the modern model, the macro view otoscope, the seal that you put on the spiculum is not as good as the former one. So he said, you know, I used to use it, but now I don't because I cannot do the seal very well. So that's an interesting information, and you can transfer that to the people. And there are some probably the way your otoscope that can make a difference for the seal. So that's interesting information that you get with qualitative inquiry.
Okay, thank you. Let's see, I've got a few comments and a few questions. I'm going to go with a follow-up comment to the one you just answered. Mm-hmm. She says, you did suggest that you would add on persuasive communication to a combined workshop. And she says she doesn't necessarily agree with that because it might be that persuasive communication could possibly deter people from doing what they're being encouraged to do instead of enhancing the interpretive effect.
That's what we saw in our study. Actually, it depends how you put it. If it's a matter of, you know, I would be with all the ads from the Conservative Party now. I would be convinced in Quebec that I shouldn't vote for them because their argument is against all the other parties and not try to promote what their goods instead of. So, I mean, it depends the message you're having.
Good. So, one other question we've got. Did you consider competing priorities as an explanation for the drop in intention at 14 to 15 months? So, this is often one explanation for poor uptake of clinical guidelines.
Can you tell me that again?
Sure. So, she said, did you consider competing priorities as explanation for the drop in intention at 14 to 15 months?
There were a few people that said time was a matter, but it was very, very few. Said time, it takes, because you have to put the spiculum on and you have to take the bulb and do the pressure. So some people it can be. It's like if you were asking for an intervention that is really take a lot of skills and a lot of time, but it's not that difficult. I said those people who integrated the technique in their routine are saying exactly the same, that it's easy and it helps them in their practice. So probably it's a matter of disbelief about clinical utility, and we have to probably emphasize this, and not so much a recommendation, but to show them that they can have a better clinical approach with their patients.
Okay, great, thank you. Another comment from questions. She said, you mentioned belief about clinical utility as a barrier to use at 14 to 15 months. Perhaps there's a role for academic detailing or audit and feedback to change beliefs about use and professional role.
Totally right, and this is, academic detailing would be something that I didn't consider in my list, but we would certainly add it. And we will use some of those techniques to add to the workshops.
Okay. Just a couple more. Lots of questions today. So this asked, how would you compare the strategies used in the workshop to components of motivational interviewing? And do you think motivational interviewing could have been used?
Yes, it could. It's just a matter of a choice. I mean, there are links between those two approaches, and especially if you using them one by one, if you do some academic detailing in some practitioner, you could use this technique, of course. Okay,
I think that's all of the questions. Thank you so much for all of those answers and for the presentation. I think we'll wrap it up then just a few minutes early. So thank you so much, and thank you everyone for tuning in, and don't forget to send your evaluation. and have a wonderful day.
Thank you very much.
Thank you. Bye-bye.
Thank you. Bye.